Thank you so much, Sheetal, for having me here and for your kind words and for allowing me to present this potpourri on the subluxated bags and dislocated intraocular lenses. So let us go ahead through this entire scenario. Now, the management in these cases, these are always challenging cases, and the management, it always depends upon the degree of the subluxation of the capsular bag that you have, and then it is you decide upon what kind of procedure you want to go ahead, what are the other intracapsular devices that you are going to use, and how you're going to manage this case. So every case in itself is a challenge that presents to you, and you need to optimize your surgery and to give good results to your patients in the post-operative period. So what I would just like to show you is, I'll start from lower to higher. We go one step higher in every complication that comes up. So this is a case, you have a subluxation, you're doing a surgery, you're trying to do a capsulorhexis and all. Now, actually what happens is when you have a big subluxations or a coloboma, you have an anterior posterior communication. That is the communication of the posterior chamber with the anterior chamber. Now, as you are seeing here at 12 o'clock position, there is a 1 quadrant gap which is there because of the subluxation. So we go ahead with the entire thing, but I would just like to put forward one of the techniques. This is the vitrectomy assisted phacoemulsification. This is the technique that was introduced to us by Ashwin. What actually came up with this was that, whenever I just paused this here because whenever we do a phacoemulsification, what happens is that wherever there is an open area around the equator where there is an anterior posterior communication, when you do a phacoemulsification, the fluid tends to go behind. And what happens in these cases is, there's a continuous vitreous hydration, and continuous vitreous hydration keeps on pushing and it makes the entire thing, the entire lens and the entire complex to bulge. So it often makes the surgery challenging. So what actually is advised in these cases is, we try to place a trocar, a retinal trocar, and we try to do a vitrectomy. Actually, this vitrectomy is not exactly a dry vitrectomy because the vitreous has already been hydrated. So this is a kind of a volvular trocar that is placed, and intermittently, whenever you have that thing entirely coming up into the anterior chamber, you can just pause your surgery, go behind, introduce a vitrectomy probe through the trocar, and then your anterior chamber, it starts deepening, and you can go ahead with the phacoemulsification procedure. So this is just a combination of a vitrectomy for phacoemulsification procedure. So I'm just trying to show you this. In this case, I just pause one more thing, that whenever the vitrectomy, what I'm trying to show you here is in this segment, whenever you're trying to do a vitrectomy in these cases, you have to be very careful that you do not rupture the posterior capsule with the vitrectomy probe. You have to introduce and place the trocar in the area where you can exactly visualize the vitrectomy, the tip of the vitrectomy probe from the anterior chamber. So you're gonna do it as a blind procedure. The rest of the procedure remains same. This is just one small tip that might come in handy to anybody who is watching this series of videos, that you can do this as a combination. Life becomes quite simpler at times, by using some of the surgical tips that I'm just trying to put forward right now. So you can see there's a shallowing. Again, vitrectomy is done. You pause the surgery. Again, go inside, and again you do, and you can continue with the procedure. You can place a CTR, and then the procedure is the routine that we do in all the cases. You can take up an intraocular lens. You can use a 3-piece IOL, a 1-piece IOL, whatever the surgeon wants to put it, and you can just end up this surgery. Actually, I try to use 3-piece intraocular lenses even in these cases, for just very simple, one simple reason that, if these patients, they come up with any other problem in future, without opening up the entire thing, I can refixate this intraocular lens as a glue diode procedure, and I can put this off as a closed chamber surgery. You need to position the haptics. Usually it is better to position it along the area of the subluxation, so that, there's these haptics of the intraocular lens, they also try to push the bag, although you have placed a CTR, so does its work. Go ahead with the pupilloplasty procedure. Single bias pupilloplasty is the procedure of choice for me. And that is how you can just wind up. You can keep on doing that procedure till you close up the entire wound that you actually want it to be. I'm just trying to show you this. This is the subluxation of an intraocular lens video. My point of showing this is nothing else, but I just want to put forward that whenever we have to expand these massive subluxations, we try to make this clearer tunnel. So this is the glued marker which has been introduced again by Ashwin. So this helps you to delineate the flats, the size of the flats. You can be bang on to it by using this. Otherwise, you can. It's not necessary actually. If you are an expert, you can just measure it and you can just do it by yourself. So this is the L-shaped incision. I'll just try to pause this video out here. An L-shaped incision is a closed incision for big scleral wounds that you need to expand the dislocated intraocular lenses. So this is actually a 3 millimeter by 3 millimeter. But you also have a 3 millimeter extension. It's a volular extension which is there inside, which helps to do this procedure. So this is how you start making up the incision. This incision, the advantage with this incision is that, it is considered to be astigmatically neutral. It is not something new that I am presenting. Actually, this has been documented quite before. In 70s, in late 70s, it has been documented, but it has actually not been adopted. I don't know why, but this works beautifully. You try and create a tunnel in this fashion, and then you also extend it internally, a 6 millimeter internal tunnel you have in this case. And then you have a comparatively bigger tunnel, which is about valvular. You can even go ahead and make, suppose if you are using a smile, a frown incision or a smile incision, whatever you are comfortable with, you can do that. But I just wanted to highlight this. You can convert this surgery into a gluteal surgery. Making up of the flaps and then going ahead. Now you see how beautifully this incision is being extended. When you extend this incision, you can just see that, this entire intraocular lens, it tries to come out in toto in this procedure. So these are just the collages, which were made for the peer review that I have put it up because it's a stepwise approach. And then, you just expand this, the iris hooks, the pupil is expanded. And what you see here is the Sommering ring, which is associated with an intraocular lens. The Sommering ring just tries to flip off and come off. It's an after cataract, which is usually present in some of the complicated cases. And you can then just grasp this and you can just expand this. Now you just see this comes out as in toto. And this works really beautifully in massively dislocated intraocular lenses. The rest of the procedure is a gluteal procedure, which I think everybody is very well versed with. You just do this, put up a fixation, and you can use a 3-piece intraocular, and then you can just do a pupilloplasty procedure and it ends up over. We go further with this. This is one more advanced stage of a subluxation of the intraocular lens. Now, what you see in this case actually is that, you have a 3-piece intraocular lens, you have a dislocated lens because the bag is also dislocated, you have a Sommering rings which is there, and you also have a posterior rupture out there. The bag is not intact. There is a posterior capsular opening associated with this. So you try to do this as a closed chamber procedure. Try to clean up or remove all the tractions which are there, even behind the capsular bag. And once you have done this, you have to cut down the capsular adhesions. When you try to cut off these capsular adhesions, you have to be very careful. And you also need to use a vitrectomy probe side by side because, before you pull out anything from the eye, because there is a vitreous all around it, you need to cut off all the tensions which are the extension of the vitreous and the strands which are there present. And then you need to just manipulate this and you need to try to clean this over absolutely. Now, the advantage that you have in this case was that this is a 3-piece intraocular lens. So we go ahead with cleaning up of this intraocular lens totally, and then doing a gluteal procedure. These are the iris hooks. This is the iris hook stopper that we use this. If we do not have an iris hook stopper, we can also use the IV tubing. You can just cut it down into small pieces, and then you can use this because otherwise you might have to open up the entire iris hook pack. So this can be used, prevents the slippage of the haptic inside the eye, and it can be beautifully used in the glute procedure if you actually do not have good assistants with you who are helping you around. And then you can just clear off this, all the adhesions that are there around. I always use a fluid infusion inside the eye when we do these kind of procedures. So you just clean up everything, put a glue, and then you seal it off and it's gone. I take this one step again ahead. Because I think I have less time, but let me show you. This is a very important case that I want to show. In this case, what you are actually seeing is that, you have this endocapsular segment out here. This is again a subluxated bag. In this case, there is also a segment inside the eye, but was not supported. And this is the reason, why this bag is further subluxated out here. This video I have presented in the ASCRS Challenging Case Symposium. This has an endocapsular ring. It has an endocapsular segment. There is a 3-piece intraocular lens also in this bag. Actually, what probably happened in this case was that the suture of the endocapsular segment has gone off. So probably this has come off anteriorly and it no more supports the capsular bag. And when you are doing an intervention in these cases, at times these massively subluxated bags might also have an IOL drop. I'll just take 1 minute and I'll just wind this up. So you can just see that this is the endocapsular segment which now comes off. And this is the suture with which it was probably tied up. So you remove this suture and then you expand this endocapsular segment outside the eye from the corneal incision. Having done that, you need to further intervene, go ahead, lift the intraocular lens, bring it up. You clear up the entire fibrotic material, the capsular bag, which is encompassing the ring and the endocapsular segment. For adequate visualization, you need to put up the iris hooks. I'm just forwarding this video. Now you see an endocapsular ring, you also see the haptic. So you need to disentangle this, pull the haptic, catch the tip, and then externalize it, Otherwise, if you do not disentangle this, if you try to pull off the endocapsular ring, it will pull on the haptic of the IR also. Now this is this is the silicone tire of the iris hook that we have started using. It works very well, brilliant, it's cost effective. As I said before, you can also use an IV set, cut it, and then you can use that plastic material out here. It's always sterile. So this is how, this is the, what I showed in the previous video, it's one step ahead of that. And then you just do a vitrectomy, remove the endocapsular, this ring. You should be very careful. It should come out in toto and it should not break. You have any adhesions, use the vitrectomy probe to clean this all around. So having cleaned this all around and externalized the haptics, catching the tip and then tucking up the haptics, then it is the same as the glue dial procedure. So I think this is what I wanted to highlight, that, whenever you have the subluxations of the bag, of the IOL, you need to be very careful and you need to choose your method of fixing up the things accordingly. Thank you so much.